Alrighty, should be recording. Let me pull up the PowerPoint. Alrighty, my name is Elizabeth Freudenberg, and today we're going to be talking about, sorry, words are hard, defining ARDS. So ARDS is also known as acute respiratory distress syndrome. So these are some anatomic alterations of the lungs that we see with ARDS. Um, so typically it'll be like a red or described as beefy or liver-like quality. I have a picture I think it's the next slide that I can kind of show you. But the lungs of patients affected by acute respiratory distress syndrome undergo similar anatomic changes regardless of the cause of the disease. So they could be coming in for a trauma or aspiration pneumonia, or could be a lot of different things. But how it will present ultimately once it's accumulated, over time or over days, um, it'll present the same. So, due to acute lung injury, pulmonary capillaries become engorged and the permeability of the alveolar capillary membrane increases. Interstitial and intra-alveolar edema and hemorrhage ensue, as well as scattered areas of hemorrhagic alveolar consolidation. These processes result in a decrease in alveolar surfactant and an alveolar collapse or atelectasis. So typically, like you'll see atelectasis or consolidation in right along with ARDS. So they kind of go hand in hand. Not to say that if you have atelectasis, you have ARDS, because that is not the case. But if you have ARDS, you most likely have atelectasis or, patchy aposities on the lungs that will show up on an x-ray. As the disease progresses, the intra-alveolar walls become lined with a thick, rippled hyaline membrane, identical to the hyaline membrane seen in newborns with infant respiratory distress syndrome, also known as hyaline membrane disease. I just kind of wanted to put this in here, or I just wanted to kind of put this in there because, in the same way that we have acute respiratory distress syndrome, we also have infant respiratory distress syndrome, right? And in a lot of ways, they can present the same. So I just felt like that was pertinent to mention. Okay, so here's the picture I was talking about. So think red, beefy, liver-like, right? Ew. So this is kind of how the lungs can present. I just thought this picture was kind of cool, so that's why I put it in here. But it's also kind of gross when you think about it. So sadly, there's over 60 different conditions currently that are associated with ARDS. So that can be something like a patient aspirating and in turn getting aspiration pneumonia, becoming septic, having some type of trauma-induced injury. So if we think about infant respiratory distress syndrome, right, we might say like, a baby that is born at 40 or post 40 weeks could develop meconium aspiration. And in turn, that could sit in the lungs and cause decreased lung compliance, right? So, in the same way, for an adult patient that aspirates maybe like, some type of food particle, could also become septic or get stiff lungs, decreased lung compliance due to that trauma to the body, right? Now, when we're thinking ICU admissions, roughly 15% are ARDS, and 25 to 30% of patients that end up being intubated and mechanically ventilated are ARDS. So it kind of puts into perspective some of the reasons why patients are intubated. ARDS is a really serious thing. It's a really serious issue. And a lot of the time, the patient has to be intubated just to give their body the chance to rest, just to maintain a patent airway, help the patient, adequately ventilate, all of that stuff, and perfuse is necessary just for them to be alive, really. So kind of like I mentioned in the first video that I posted, typically patients with ARDS will present with crackles. It could be crackles, or it could be diminished breath sounds, shortness of breath, tachycardia, diaphoresis, right, excess sweating, or increased accessory muscle use. There's a ton of symptoms though that they can present with. There's just a few. So the Berlin definition, I don't know why I thought this name was cool, but the Berlin definition is basically a diagnostic, ARDS criteria that says respiratory symptoms that have manifested over the course of 1 week or increased symptoms over the last 7 days due to a new clinical incident or worsening circumstance. So the first step is just ruling out other conditions, other pulmonary issues like pulmonary edema that could also present in a lot of the same ways. When we think of crackles or diminished breath sounds, right? That's a symptom that across the board can be a lot of different things. So it's important to rule those things out first. So this is some more diagnostic criteria. When we're talking about ABGs, mild ARDS is typically acute hyperventilation with hypoxemia. Moderate to severe ARDS will start to see acute ventilatory failure with hypoxemia, and then the PF ratio will decrease. So a PF ratio is just your PaO2 divided by your FiO2 for a patient that's being mechanically ventilated. That may be used to just quantify the degree or the presence of ARDS or hypoxemia. So it's kind of putting a number on how bad off are they and what do we need to do now to try to fix that issue. So when you think ECMO, right, a patient has to be at a certain degree or PF ratio in order to meet criteria to be on ECMO. And so it's just putting like a number value to the degree or the severity of their lung issue. So this is just kind of breaks it down. I really wanted to put this in here. I really felt like this was important information, especially with the PF ratio. A PF less than 300 torr is going to be hypoxemia. They're going to meet the criteria for mild ARDS. A PF ratio of less than 200, it's going to be severe hypoxemia and moderate ARDS or acute respiratory distress syndrome. And then a PF ratio of less than 100 torr, it's going to be severe. So both acute respiratory distress syndrome and acute lung injury, they both take time to develop. They're not something that a patient's going to just instantly have, right? We'll kind of see it progress. So that's also why we're able to collect data and gradually try to change the treatment or manipulate the treatment to help the best outcome of the patient. And then these are just some other like diagnostics, I guess. So for PFTs, you would have decreased volumes. Obviously, you're going to have a decreased functional residual capacity, right? So let's say we're doing like some type of bedside spirometry with the patient that is starting to exhibit these symptoms. You're going to have an overall decreased total lung capacity, right? Because as their lungs get stiffer, their compliance decreases, they have an increase in resistance. They're not going to be able to take in or withhold as much air. So overall, it's going to be decreased. And then on a chest x-ray, a lot of times they'll have this ground glass, like grainy type of appearance. And that's just kind of used, they typically will get an x-ray and see that to kind of confirm that it is ARDS. So yeah, so kind of like what we talked about just before, some clinical manifestations. The patient can present with shortness of breath. If they're hypoxic, right, they're going to be kind of confused. Think like, moderate to severe hypoxemia. There's not enough oxygen going to their brain. So they're confused. They don't know really what's going on. And then if you tie that into like low blood pressure, well, now they're feeling dizzy, they're feeling fatigued. Maybe they have an increased work of breathing or are really labored, like shallow breathing. So all of these things can play in. Okay, the 5 Ps of ARDS. So I don't remember us learning about these. It could have been that I just like forgot, um, or maybe wasn't paying attention when I should have been. I don't know. But I just looked them up, and these are the 5 Ps of ARDS therapy from what I could find. So we have perfusion, um, which is just essentially blood flow, right? So we want to maintain good blood flow. And one of the ways that we can do that is through positioning, um, protective lung ventilation, protocol weaning, and then preventing complications. So there was actually a patient that I got to see at one of the hospitals, severely obese patient. I'm just using him for reference because a lot of the P's were applied in this situation. So he had decreased perfusion. Um, we were proning him um, once a shift. So they would prone him, and then they would put him back to supine, and then they would prone him again. Um, and it was really just to try to, increase his oxygenation because he would kind of, no matter what they would do, he would kind of sit in like the 80s. Really, really like severely obese patient. I want to say like around 500, maybe even a little bit more. Um, had some can't talk today. I'm sorry, emboli at the bottom of his lung bases. And so they were also um, trying to um, position him better for oxygenation because of that. And then they used a lung recruitment strategy. So they did the stepwise approach where you like gradually increase the PEEP up to 20, like every 3 to 5 minutes. And then one of the RTs also mentioned that they did a different protective lung maneuver where they did in CPAP, they did the patient for 40 PEEP for 40 seconds. And that was ordered by the doctor. And both of those things appeared to help. I saw the stepwise approach, but the other one they also mentioned appeared to help the patient. And then obviously preventing complications, right? So anything that we can do to help the patient and not hurt them. Lastly, these are some cross-sectional images of ARDS. To be honest, I'm not that familiar with CT imaging. These are just ones that I found online, and I included this one at the top because it kind of goes over, kind of shows like the lung consolidation, like where it is and everything, and then the area that's uninvolved. In the anterior portion, it says, and then I found this X-ray kind of cool because it's a transition between lobar pneumonia to ARDS. So on the left side, you can really see how there's patchy areas, there's some of that black, right, like that air, and then it gradually gets worse. on the right side. It is like tremendously worse. So I just found it kind of interesting. It kind of like shows the difference. Um, so yeah, alrighty. So we went over a lot today. We defined R's. We went over PF ratio, right? So the degree or like the number value um, to um, defining the severity of ARDS. We went over some x-rays, some CT imaging, the 5 Ps of ARDS therapy, and just kind of broke down some of the signs and symptoms and the diagnostic criteria. And then just kind of gave an overall uh, a teleology and all of that as well. So yeah, thank you very much. Let me just